It is my honor to introduce our next speaker. Our next speaker is Glenda Lise Vasquez. She is our Chief of Pediatric Rehab Medicine, and she is going to talk to us today about early detection and early intervention in the patients with cerebral palsy.
Thank you so much. Good morning to all of you. I'm going to be talking about why early is best. I think the context of this, I don't have any disclosures. Sorry, they want me to show you my pretty smile. Let me see. All right. I don't have any significant disclosures. The context for this talk or this lecture is that most children get diagnosed with cerebral palsy, actually between the ages of 2 to 4, and there's reported healthcare disparities that we've seen with reported delays in diagnosis and therefore interventions for children who are Black and Hispanic or Latinx. So hopefully as we talk about this, we can talk about why early diagnosis is important and interventions. Can I go back? All right. CP is the most common physical disability in childhood, and the variation in birth prevalence exists in high-income countries. It occurs because of a lesion, injury, or maldevelopment in the developing brain. Yeah, thank you. I would appreciate it. And it is, though, a clinical diagnosis because there are no biomarkers for the diagnosis of cerebral palsy. Traditionally, it has been diagnosed between the ages of 1 to 2, but like I've mentioned, there are specific populations that sometimes get delays in diagnosis. It is diagnosed because of a combination of pertinent history, clinical signs, neurological symptoms, and physical examination findings. And impaired movement is the main presentation. We can see delayed motor milestones. It's associated with exaggerated reflexes, but we can also see floppiness and or spasticity in infants, unusual postures, and involuntary movements, or a combination of all these. About 10 years ago, there was a reported increase in prevalence. There was noticed that more premature babies were surviving with more motoric impairments. There was an update reported by OSQE in 2018, and he actually reported that the overall prevalence of cerebral palsy has remained constant from 2007 to 2018. However, it probably is because there's a balance between increased prevalence factors, such as prematurity, of extremely very small preemies, and also an increased incidence in multiple birth, and a balance of that combined balance with factors that actually decrease the prevalence, such as the use of antenatal steroids, cooling, or even using mag sulfate. Birth weight risk, actually this is the most, they also kind of like reported an update about this, and birth weight specifically, very low birth weights, less than 1,500 grams is the highest risk for developing cerebral palsy. And then in relation to gestational age, decreased prevalence with gestational age is seen, decreased prevalence is seen with higher gestational age. So the higher risk rates of those with earlier than 28 weeks of gestation. And then we see also very low incidence with infants that are born 32 weeks and older. We've also seen a prevalence declining in Australia and in Europe, but the exact rates in these countries, in countries that have low to middle incomes, is less certain. So we sometimes don't have reports on prevalence beyond developed countries. In terms of etiology, the true cause of cerebral palsy in an individual is most likely a complex interplay between several risk factors across multiple periods of time, including there's new evidence suggesting that even 14% of cases potentially may have a genetic component. The specific pathway that will result in CP is unclear in approximately 80% of cases, but risk factors are often identifiable from history taking about pregnancy, conception, birth, and the postnatal period. In developed nations, the most predominant causes, as I've mentioned, are prematurity, especially lower than 28, and then extremely low birth weight. In developing countries, they're still coping with infections such as Zika, rubella, internatal hypoxia, and postnatal hyperbilirubinemia. Historically, we have been assessing risk mostly by history taking, identification of risk factors through newborn and infancy and childhood periods. Such as in newborn, we have detectable risks, as I mentioned, preterm. We also have hypoxic ischemic encephalopathy, and just history of either neurological conditions or risks, and then detectable risk in infancy, such as just parental concerns, comparison of development, and once the child is discharged, also the inability to sit by 9 months of age, or hand-arm asymmetry in how they're doing their motor control. All of these things will warrant additional investigations and a full evaluation. Can you just hit the video at 1? Okay, thank you. Oh, I click it?
2-month-old, typical, atypical motor development.
I'm just going to talk. In addition to the medical history and neurological evaluation as just, typical physical examination of infants, there are additional tests that may give us clues. And either they might give us reassurance, right, of the overall development of the child, or it can also give us the ability to identify atypical movements, which may warrant additional evaluation and management. This is just a brief video, an example of motor testing of a 2-month-old. Side by side, we have comparisons of what a typically developing baby is moving, and then atypical signs of movement patterns on the other baby. Actually, this website, pathways.org, provides video examples of general movement testing for infants of different ages, which is a great resource for review for general practitioners and clinicians, and also for trainees, for medical students or pediatric residents.
Begins to show extremity anti-gravity movement.
We also have additional standardized testing. There is the Hammersmith Infant Neurological Examination. It is easily performed and relatively brief, a standardized neurological exam of infants. It has a good intra-observed reliability, even with less experienced staff. So we actually can get people trained, additional clinicians that are not physicians, like physical therapists or occupational therapists on HINE. And HINE can further help identify those infants needing specific rehab programs. It includes 26 items assessing cranial nerve function, posture, quality and quantity of movements, muscle tone and reflexes and reaction. Each item is scored individually. And there's also a sum score of all the individual items. And then we can also have sequential testing. And the use sequentially will allow us with early signs of cerebral palsy and other neuromotor disorders. Individual items can be predictive of motor outcomes. For example, in preterm infants assessed between 6 and 15 months of corrected age, scores greater than 64 predict independent walking with a sensitivity of 98%, and specificity, and conversely, scores less than 52 were highly predictive of CP with severe motor impairments. And this is actually better than the old kind of like rule or a dash sit by 2. So we could potentially diagnose patients around the age of 6 months of age, corrected age. And that's an example of the reporting form that we can use as observers. And click it again. And I included in the references the article for HINE, and there's actually a If you can maybe go to like 10 minutes, minute 10. They actually have a link to like their YouTube video of a whole hind examination, and you can see what it's all about. But it can actually take about 10 to 15 minutes to do a full neurological examination of all these things on infants and have a really good idea if there's any red flags that warrant additional evaluation. So, historically, we've had this silence period from 12 to 20 months of age. We've regarded this period like, well, we'll just watch and see what your child does. However, nowadays, there is we can actually diagnose children with CP, or at least a high risk for cerebral palsy, as I mentioned before, the age of 6 months corrected age. The 3 tools with best predictive validity for detecting CP before 5 months corrected age include a neonatal MRI, the Bradshaw qualitative assessment of general movements, and the hind. After 5 months of age, corrected age, we also can use an MRI, the hind, or developmental assessment of young children. Late diagnosis means some infants will not receive early intervention when they would benefit the most, because these are crucial periods. So in order to make a diagnosis, we will need a reduced quality of general movements or neurological abnormal movements, which we mentioned as suboptimal hind scores or early observable hand asymmetry. And these will indicate that motor dysfunction that is required for a diagnosis of cerebral palsy. In infants younger than 2, motor severity is really difficult to predict. So we can see that the child has a motor impairment, but sometimes we might not be able to predict how severe that motor impairment may be going forward. Why is this? It's because almost half of infants younger than 2 actually end up with their GMFCS reclassified. Later natural history exists for this age group in terms of onset and type of motoric impairments. The presence of hypertonia changes and evolves with time, and there is rapid growth and use-dependent reorganization, aka neuroplasticity, in response to caregiver, therapy, and other environmental factors. So cerebral palsy can be classified through motor types. There are 4 motor types that exist. They can emerge and change during the first 2 years of life. The majority of patients are going to present with spasticity, and spasticity may even occur after the age of 2. Lack of presence of spasticity before the age of 1 doesn't mean that the child does not have cerebral palsy, though. We can also see dyskinesia with fluctuating tone, including dystonia and anatosis. We can also have ataxia and hypotonia. Ataxia and hypotonia and dyskinesia tend to be less, they present less. As an infant motor volitional increases, some symptoms may resolve, some symptoms may worsen. For example, this may happen with dystonic posturing. We can also classify cerebral palsy with anatomical distribution. Dyskinesias, ataxias, hypotonia typically will affect all 4 limbs, while spasticity we can classify depending on the limbs that it's affected. We can see hemiplegia or unilateral in about 38% of patients. We can see diplegia, in which the lower extremities are more affected than the upper extremities, in about 37% of patients, and then quadriplegia, in which all limbs are affected. Typically, lower extremities are more affected than the upper extremities in 24% of the patients. Neuroscience evidence indicates that brain development continues postnatally, driven by motor cortex activation. Therefore, activity-based interventions are essential because those infants who do not use their motor cortex risk losing connections and dedicated function. There is increased evidence that the infant's behavior through interaction with their environment help control and generate growth and development of muscles, soft tissue, in addition to the neuromotor system. This is why it's so important to diagnose and detect early so the child can be referred for early interventions. Depending on the ongoing impairment, cerebral palsy-specific early interventions maximize neuroplasticity and will minimize complications to muscles, bone growth, and joint development, and optimize outcomes. Not all ECI programs are the same. They varied in frequency, type of intervention, content, focus of intervention, so therefore no real conclusions can be made about how effective they may or may not be. The ideal duration and frequency of programs and interventions are also not clear. Identification of the distribution of motor impairments early may aid in identifying different treatment strategies to optimize and improve outcomes. For example, studies have shown that infants with bilateral cerebral palsy who receive regular surveillance and intervention have lower rates of hip displacement, contracture development, and neuromuscular scoliosis. On the other side, hemiplegic cerebral palsy, especially those patients who receive CIMT, which means constraint-induced therapy, have better hand function than controls. Also, in infants, interventions at home has shown better improvements overall. A very intense and promising intervention that can be offered at home is GAME, and it's not playing with your child. GAME stands for G, it's goal-oriented, and then A is for activity, and ME is for motor enrichment. So the part one is that goal-oriented intensive motor training. Families collaborate with the therapist. They're going to determine a specific set of goals for the child's development. The goals are going to relate to motor development, and the therapists are going to play an important role in helping the parents set realistic and appropriate time frame goals. As goals are attained, new goals are identified. The therapist assess how weakness, selective control, alterations in tone affect the difficulties that are noted by the family, and then solutions are identified. Part two is A for activity, and actually the parent is educated and grounded in family-centered approach, and the parents are going to be coached to identify the child's attempt to activate and volitionally move and self-regulate. They're also educated in potential trajectories to enhance development and stimulate the process. And then the last part is the motor environment or environmental enrichment, in which the interventions are going to happen at home, where they can assess the child's environment and how it may hinder or optimize the child's development, and the parent is coached in regard to toy selection, physical setup of areas, repeating and practicing the activities related to identified goals. And they're going to use typical like baby toys for all these things, so not a lot of like equipment, specialized equipment will be needed at this stage. And then what happens beyond infancy? Even beyond infancy, access to knowledgeable therapists can improve outcome potential and skill acquisition. We want child-initiated movement, target motor training activities, and task-specific and context-specific exercises. This is an amazing chart, but it is very busy. And it has been published in a systemic review of the literature. And the authors basically use a traffic light system after completing this review of the literature for the prevention and treatment of specific impairments related with cerebral palsy. And we're just going to touch base on a couple. However, as a physical medicine and rehab or physiatrist, we can assist in the management of these early interventions for children with CP or at high risk for CP. We will assist with surveillance for hips and scoliosis. We assist in optimizing interventions, making sure that the patients have access to ongoing therapeutic sessions that make sense for the patient and the family. In addition, most patients will develop a specific type of motoric impairment, and the interventions that one child may need may differ from the interventions that another one may need. So basically, we're kind of like, so we assess all these potential interventions and also help explore and tease out with the family which are worth pursuing, which are, who knows, it might help, and which are, you shouldn't even try. So, for example, CIMT, there, the clicks are. CIMT stands for Constraint-Induced Movement Therapy. It includes intensive motor practice with restraint of the uninvolved extremity. There is formal CIMT, in which the child is going to have basically limitation of the unaffected limb with 3 hours of therapy a day for at least 2 consecutive weeks. There's modified CMT, in which requires restraining the unaffected limb for less than 3 hours a day with therapy. And there's also some force use therapy, which involves restraining the unaffected limb with no additional therapy. So the jury's out on this in terms of frequency and duration. There has not been determined that there is like a right answer between which type of CIMT is the best. We just know that the methods include bivalve cast, STORM cast, sling, fabric glove, built-in volar, plastic splints, or whatever. We just know that early intervention with this type of rehab on hemiplegic patients with hemiplegic CP actually improves hand function compared to controls. And actually, it started with the eyes, then it's basically a similar philosophy of patching. And when we started doing this in children, we started noticing these changes. So there's actually adult data that shows motor reorganization with this type of therapy. And cases has shown that cortical reorganization in functional MRI in similar patients with adult stroke. So if adults can do it, our kids can do it, and better. So partial body weight support treadmill training is another targeted intervention. It is very task-specific and repetitive, and evidence supports for motor interventions that are goal-oriented, promote task performance, which can be translated and practiced into real-life activities and tasks. So if you're practicing walking, therefore you have a higher chance to be able to walk over ground, right? So that's kind of like where it comes from. We're using self-generated movements and high-intensity repetition and practice. And the mechanism of action is experience or activity-dependent plasticity. Okay, so we see the worth it line and probably don't do it and don't do it, okay? So neuroplasticity is highly affected by motivation and attention. Task-specific practice that is enjoyed and reinforced in the child produces spontaneous regular practice. If the child hates it, probably they don't want to do it again, okay? So if we look at the interventions at the bottom of the chart, we can see more passive interventions, right? The child probably is not engaged in doing. There's a very limited activation of any kind of like motor, probably a lot of like passive repetition or interventions that actually the child doesn't even participate in it in a sense. Because there's no requirement for a child to integrate itself, they really don't have evidence or efficacy for some of these in the red spots. Okay, so we discussed how specific interventions may assist with skill development in children with CP and how important early provision of these interventions may be to unlock the outcome of our patients. So PMR longitudinally will follow patients with CP and aid in this to prevent ongoing complications such as joint deformities, contractures, scoliosis, among other, with implementation of bracing, identification of appropriate equipment, and provision of aggressive tone and spasticity management. And talking about tone management, so hypertonicity or spasticity is a major contributor to secondary impairments that are going to progressively lead to activity and participation restriction as the child ages. If spasticity is causing pain or interfering with motor development, management needs to be considered. So this figure demonstrates the different interventions that we can provide for children with CP to assist with tone management, contraction and alignment management. And again, the earlier that these are implemented, the less the musculoskeletal complications and related comorbidities, and therefore include quality of life. So through our program, we provide management with all of these interventions, from oral enteral medication, local chemodinervation procedures such as botulinum toxin. And we also we always consider the child's functional and personal environmental factors and potential goals in the treatment plan that is developed. In addition to the typical pediatric PMNR, this year we actually launched the combined spasticity clinic, or the combined advanced pediatric spasticity clinic. And this is going to be used to enhance and centralize the management of patients who present with spasticity and other movements. So the child will get a comprehensive evaluation for management and optimization of rehab interventions, including skill acquisition and mobility. So as part of this comprehensive eval, the patient is evaluated by all team members, including a pediatric physiatrist, a pediatric neurosurgeon, physical therapy, and occupational therapy. We have a rehab coordinator for this clinic and a social worker. And our team discusses our findings and will provide recommendations. And hopefully in the future, we would have access to gait lab analysis and other evaluations that can target interventions a little bit better. So takeaway points, collaborating to develop a follow-up clinic with trained clinicians for high-risk patients may actually systematically identify patients as less than 1 year of age, hopefully around 6 months of corrected age. Not all rehab interventions are the same, and early referral can assist with joint surveillance and maximization of toe management to decrease impact in function, and these things are essential for improvements of outcomes in this patient population. Thank you. Any questions?
How do you counsel families who ask about things like stem cell therapy and hyperbaric oxygen? I know those were in the yellow and red of that chart, not really recommended, but what do you actually say to them?
Yeah, it is an interesting topic. It is difficult sometimes to navigate these with the families. I typically talk about how my responsibility as part of do no harm sometimes is do no financial harm, and that some of these interventions are actually not as innocuous as we think they are. I think a lot of people have forgotten that back in the 70s and 80s, hyperbaric chambers will explode and kids died. There can also be viral trauma. A lot of our kids may have pumps, and it can affect actually pump function. Like the metal can actually, because of the changes in pressure, they can dent. So I do my best to kind of like answer questions. At the same time, I cannot penalize the families that want to do it. I try to think of it as, what are the other things that the child would need and how can I help? So yes, you're going there for hyperbaric, but are they getting therapy? Are they doing these things? Because not having the standard of care may actually affect the child. So that's as much as I can do in a sense. Unfortunately, if we actually talk with these families, a lot of data they're getting are from their own peers, and scientific data, it's really not prioritized when they make this decision. So even if we come with, hey, there is this nice chart and look at the scientific evidence, there has been a shift in the scientific value for these families, and the values may just be different.
Thank you so much for your talk. I'm wondering, for pediatricians in the community, when they take care of kids with cerebral palsy, what types of patients are good to refer to your clinic, and how do they kind of differentiate? Where do they go to a general neurologist? Do they come to you? Where does that process lie?
Yeah, I'm smiling because I'm actually writing a manuscript about just that, about what's the difference between pedi-neuro, pedi-ortho, because we tend to treat the same patient population. I see us as like the functional, part of all of these things, especially kids that have motoric impairments, mobility issues that require advanced equipment, advanced interventions. That's our language. We know that not all therapy is the same. We know that not all wheelchairs are the same. We know that not all braces are the same. We're specifically trained on these things. And we also manage non-operative a lot of these alignment issues, tone issues. So hip surveillance, the diminishing musculoskeletal deformities, that's also what we do. So I typically see, and correct me if I'm wrong, almost all kids with CP, if they have some sort of motoric involvement and or spasticity, probably should be seen by a rehab physician, because that they look fine when they're younger doesn't mean that they're not going to develop a contracture as they age, or that they don't need a brace. And kids are going to move and they're going to do weird stuff with their body. And then I see them when they're 12 and I'm like, I wish you would have seen me 5 years ago, you know? So that's kind of like how I see it. Sometimes they send me kids with CP that are doing everything though, just because they have CP. And they maybe have a very, very, very mild hemiplegia at the age of 14. And if they don't have any tone contracture or any issue, I'm like, okay, I'll talk with the family and I'll be here just in case. But and then I see patients that I directly send to ortho, for example, but ortho may not have the time to discuss a lot of these functional environmental issues, and the family think that the kid is getting everything that they need just because they're seeing a physician. So kind of like, you know, and sometimes kids just need additional diagnostic workup. You know, the people love to send me toe walkers, and I'll see toe walkers, but not all toe walkers because of cerebral palsy. So, you know, and then I'm like, hey, have you seen our friendly neuro doctors? You know, so that's kind of like how I see it. And then developmental pediatrics, sometimes they send me kids with autism, and that's more of a cognitive intellectual, and I may be a little bit equipped for that, but probably they should be seeing developmental pediatricians or neurodevelopment for that, because of the lack of that motoric mobility issues.
I had a question about what is your threshold, because you mentioned earlier not all therapies are the same. What is your threshold to refer to additional therapies once a child is maybe already getting ECI services? Is there a certain age at which you say they should be getting more, like a certain frequency per week, or are you gauging it based on their progress in therapies? How do you approach that?
For me, CI is for kids that are almost near normal or normal and just at risk. So they can provide developmental guidance and play for families. I do think that kids that already have neurological impairments will be better served with either home full therapy or outpatient therapy. Typically, though, I tend to wait until the age of 1 to really kind of like push for outpatient therapy, unless there is a high kind of like knowledge gap in terms of the home therapists that are being provided. Also, not all home therapy programs are the same. There are some therapy programs that are basically coordinated by a home health company, and they're based off nursing, and there might not be a lot of guidance and support from knowledge and interventions from their leadership for therapists. So you can end up having adult therapists in kids because there's really no limitation for that. And there's some home therapy companies that are actually therapy built. You know, like the leadership are therapists, and they expect specific kind of like competencies from their therapists. So therefore, my clinic appointments take forever, because sometimes I like engaging the therapist, because it's an access issue sometimes. So sometimes I prefer to access therapists and see if we can change the interventions. If we're not going anywhere, then sometimes we just need to rewrite that plan. The other thing is that families think that they can be in therapy forever. And then they may have like 20 visits a year or something like that. So it's kind of like the understanding that skill acquisition happens with repetition. Diluting 20 visits in a year doesn't necessarily lead to skill acquisition. And there's also a need for accountability and responsibility for parents. They need to start learning home exercise programs early, because once the child turns 18, they turn into a pumpkin and they cannot access the pediatric services, and then the families were never trained after 18 years of therapy interventions. So I sometimes tend to do outpatient bouts, home therapy, home exercise program. It's basically used almost like a medication, you know, like you have different doses and concentrations, and one therapy intervention may help skill acquisition, et cetera. So that's how I see it.
Thank you. Can I actually ask you one more? What have you seen over the course of the pandemic in terms of, one, obviously a lot of therapies are happening virtually. Are there are there any good resources online or videos that you can recommend to families who are wanting to learn to do some of these things themselves?
That has been difficult, and it actually has been reported in the literature how COVID pandemic has affected conditioning, access to therapies, and even function in our kids. Virtual therapy is not the same thing as real therapy. Then it's also compounded by not going to school, and I think we really minimized activity, just transferring to the wheelchair, getting to school, staying awake, moving, maybe getting into a standard in school or something. Like our kids really develop contractures, a lot of chronic pain, hips popping out of socket because of access issues. It's important to keep kids in a routine. And that's why I've always believed in accountability for parents, because if they have known home exercise programs, it would have been easier than to be the hands of the therapist and to help their kids at home. I think we are very busy, so there's like, oh, he's doing therapy, I don't need to learn any of this. So these are things that I really talk to parents about, to integrate it in their home life and their routines. Thank you.